And Joanna, Dr. Bailey, if you're good, we'll do your case first right after the didactic, if that's okay. Hopefully so.
Sure.
Whatever you'd
Not going to be annoying.
You'll be right. So just use these arrows there.
Oh, okay.
I'll keep these.
All right, so today we're going to talk about why genotype and fibrosis really matter. Can you guys hear me okay? Okay, I'll take that as a sure. I'll see a head nod. So just a quick review of the Hep C life cycle, because we really don't play it down to the micro level too often, but Hep C, it's a single-stranded positive RNA virus, and it's comprised of envelope glycoproteins that are arranged in a lipid bilayer, and then those contain the RNA virus and then your viral core protein. So once the virus enters your hepatocell, or hepatocyte, then it's translated through various host machinery into polyproteins. Those polyproteins are then cleaved by both the virus and the host proteases, and they form various mature proteins before they're released from the cell. So how does a Hep C genotype play into that, or what the heck does that even mean? So basically, your genotype, it's an expression of the viral heterogeneity, and this plays a role in the diagnosis of infection, the pathogenesis of this Hep C disease, and then also the treatment response. When you think about the genome, it's about almost 10,000 nucleotides, so there's a lot of room for error. The RNA virus can't really proofread itself. So on average, with each replication cycle, and then keep in mind, this is also a very fast, quickly replicating virus. So billions of new viruses are made on a daily basis, but with each replication cycle, you have the opportunity on average for about 1 to 3 errors or mutations. So lots of room for heterogeneity. Sometimes it matters and sometimes it doesn't, and that's what we'll talk about today. So there are 6 major genotypes, and then there are hundreds of subtypes. The evolution of these genotypes is likely influenced by multiple things. Some includes immune selection, infection patterns, replication efficacy, and population migration. And this has really led to specific geographic distributions amongst the genotypes. So this is from Hepatology Journal in 2015. This is the global distribution and prevalence of Hep C genotypes. And so the red is genotype 1, which, as we've discussed several times, this is our most common genotype. Really in US, Latin America, and Europe, clearly the predominant. Genotype 2, we see more in India, also Norway and Finland, and some of the Far East countries. Keep in mind though, genotype 2 and 3 in West Virginia makes up still about 30% of our Hep C cases. Genotype 3, we see more in West Africa. Genotype 4 is more central and Northeast Africa. Genotype 5, Southern Africa, and then genotype 6, it's really hard to see because it's really, really small pinpoint to the right of the green. But that's more in Hong Kong and Vietnam. So when you have somebody coming in, we really don't tend to see 4, 5, or 6 very often in the United States. But if we do, it may clue you into to ask a little bit deeper travel history as well. The clinical application is that determining these genotypes really helps to guide our decisions about treatment. As certain treatment regimens, dosing, and the duration of therapy can really vary across these genotypes. So this again is your Hep C RNA virus, and these are the various direct acting targets. Really what I want you to take from this is that there are several target sites along the HCV genome. They really act, our DAA agents really act on at least 2 different target sites. and they really are intended to disrupt the replication process. So I have it squared off if you can see, but our main classes are the NS5B polymerase inhibitors, NS5A inhibitors, and NS3 and 4A protease inhibitors. So next question is, now that we've moved to an era of pan-genotypic agents, are genotype and subtype really even necessary anymore? I don't know. We'll see. So we'll come back to that. First, I want to talk about liver fibrosis because this plays a big role with genotyping as well. So fibrosis is the excessive accumulation of extracellular matrix proteins, including collagen, and this occurs in most types of chronic liver disease. Can result in cirrhosis, failure of your liver, portal hypotension, and ultimately could lead to liver transplantation or death. So a review of our stages of liver fibrosis. Stage 0 is not off here because that's a healthy liver. Stage 1, liver inflammation. Stage 2 is when you start to see some limited accumulation of scar tissue, but still have preserved liver function. Stage 3 is what we consider bridging fibrosis, where there's extensive scar tissue and fibrosis, but still relatively normal liver function. And then stage 4 is when we really see substantial scarring and ultimately impairment of vital functions. In the sense of liver fibrosis as related to chronic HCV progression, once the liver is infected with hepatitis C, about 55 to 85% of Hep C infections become chronic, and then over a period of decades, so 20 to 25 years, another 20 to 30% will eventually develop cirrhosis. 80% usually will not develop cirrhosis. And then of those, at about the 25 to third decade mark, you start to see HCC, hepatocellular carcinoma, develop about 1 to 4% of cirrhotic patients per year, and then end-stage liver disease 2 to 5% per year, ultimately resulting in death. Some additional factors associated with HCV liver fibrosis progression. So we divide these up into non-modifiable and modifiable host factors, as well as our viral factors. Some things to point out, because I don't see these on, this is from the IDSA AASLD guidance, this table, but some things that I didn't see on here that we could point out too. So non-modifiable risk factors, we have fibrosis stage, inflammation grade, older age at time of infection, also consider duration of infection. So maybe a new diagnosis, but may have been infected for several decades and just not previously diagnosed. Male sex and organ transplantation or immunosuppression with a solid organ transplant. Modifiable host factors, alcohol consumption, NAFLD, obesity, insulin resistance, also iron overload, and there's some associations with cigarette smoking and or tobacco use and liver progression as well. And then our viral factors, genotype 3 has been known to progress liver fibrosis at a faster rate, and then co-infection with Hep B or HIV. So is fibrosis important? Absolutely, this is essential. The morbidity of Hep C infection is not necessarily from the Hep C virus itself, it's almost completely related to the development of cirrhosis in that population. If they have cirrhosis, then that increases your urgency to get on treatment and may also affect the regimen choice, duration, and whether or not we use ribavirin. Just to revisit the modalities that we tend to use to assess fibrosis are elastography or fibroscan. We truly have limited access to this in West Virginia. I know of maybe 5 facilities that have elastography in West Virginia, and Dr. Tierney's clinic is one of those. So we tend to do a regular right-upper quadrant, yeah, girl. Ultrasound. That's not pretty insensitive to identify cirrhosis. So if it's there, it's pretty good likelihood that's real, but if it doesn't show that there is cirrhosis on imaging, you could still have cirrhosis. Keep in mind, another reason we do ultrasound or do imaging is to assess for HCC. before treatment. Again, if they're already cirrhotic. We also have various serum biomarkers. We use the fibro test or FibroSure. Oh, and then just a caveat, but the FibroSure or fibro test and then the elastography, those are about $450 a pop. So if you have access to both anymore, I tend to say maybe not use both. But if we only have access to one, certainly we should have one of those modalities utilized. Some quick and easy calculations that you can do in office are your AST to platelet index ratio, I can't even talk, index ratio, and then your Fib4. There is an app I use, it's the QX calculator or calculator by QXMD. It's an app you can download and it has all of these scores. The AST to platelet ratio index, you just divide the AST divided by the upper limit of normal for your reference range AST value, divided by your platelet count, multiplied by 100. That one you can figure out. The Fib4 has a square root, and I never have ever memorized that one. But both of those give some fair indication as to whether or not there's underlying cirrhosis. Not great, but pretty quick and easy to do. We rarely use a liver biopsy anymore. I wanted to include a slide specifically about the elastography, just so that you can keep in mind, this is not used just for hepatitis C assessing fibrosis, but you also need to keep in mind that the cutoff ranges can vary based on which liver condition or underlying disease process you're looking for. So for hepatitis C, I mean, there's several studies. There's a little bit of a wide range. Some say 11.9 is your cutoff for cirrhosis. Some say 12.5. But the data has really kind of landed on if you have a higher than 12.5 kilopascals, pretty high certainty that there is underlying cirrhosis. And again, remember the kilopascals, this is measuring the stiffness of your liver. Other things to kind of point out, so there's a lot of things that can actually influence this test to give it a higher score. One thing to point out is obesity certainly can, and many West Virginians are obese. Also, eating a meal right before the test can also give you a higher calculation, as can liver inflammation or a particularly high ALT value. So if you have an elastography value of 19 and all of your other calculations suggest no concern for advanced fibrosis, I probably wouldn't believe the elastography, or at least take into consideration those other confounding factors. But it's a little bit reassuring if you do have someone that you bring in and their elastography value is pretty low, you can be more confident that there is not any underlying fibrosis or cirrhosis. So if you've established cirrhosis is present, then what do? First steps before treating your Hep C, you really want to determine if there's any history or signs of decompensation. Why? Because this will affect your choice of regimen. We don't use protease inhibitors with our decompensated cirrhotics because it can worsen their disease. And we tend to add ribavirin. Also, consider it could affect the safety to the patient. You want to let the patient know signs and symptoms to watch for worsening decompensation and monitor them closely. In your cirrhotic patients, we tend to calculate the Child-Pugh score and then the MELD NA score. These, again, that calculator that you can download is an app. It has those on there, but basically both of these tests help to determine the prognosis of your cirrhotic patient. And they can also help you determine if they need a liver transplant evaluation. So underneath each of those points are the various factors that are used in those calculations. But again, I just plug those into your calculator. Some other important points to comment on. So remember, with your decompensated cirrhotics, they can worsen at any time. It's not a linear progression. I kind of use the analogy, it's like walking through a minefield. You just don't know when they're gonna, what day it's gonna be. That's their unlucky day. Make sure that these patients, we tend to not treat them. We refer them to a hepatologist, or at least you're working in very close conjunction with a hepatologist and or a transplant center. Understand that even though the protease inhibitors are contraindicated, there still is potential for liver injury even in the absence of PIs. And then again, typically for Hep C treatment, we would add ribavirin. We don't know why it works, but it seems to increase the sustained virologic response rates. However, there's a lot of toxicities associated with ribavirin as well. And then the other thing, I always like this term of MELD purgatory. So just when you're calculating your MELD score, remember this is to help determine the prognostic or prognosis of your cirrhotic patients, and may help guide whether they need a transplant evaluation. So there's kind of a sweet spot to where you can still treat a decompensated cirrhotic, and it can actually improve their cirrhosis enough that they can avoid transplant. But if their MELD is over a certain number, or they have Child's PUC, the risk of attempting to treat hepatitis C may actually not be of benefit to them. It will actually just delay the inevitable. You won't be able to improve their liver disease enough by treating their hepatitis C to avoid a transplant. So I tend to say, you know, in ECHO, I would use a much lower threshold of a MELD greater than 18 to assess for that. I'd say anything above a MELD 12, probably refer them on to Jean over here. But usually the threshold, if you've been doing hepatitis C for a while and feel more comfortable with kind of teetering for our decompensated cirrhotics, MELD 15 to 18, you still may be able to treat them as long as you're watching them very closely. So back to our Hep C agents, our direct acting pan-genotypics, which brings us back to the question of does it even matter to even check a genotype anymore? So right now we have 3 pan-genotypic agents, but the last one listed there is a salvage regimen for treatment experienced patients. So we don't tend to talk about that one. But we have Epclusa, which is an NS5B inhibitor and NS5A inhibitor, and then Mavorite or glisaprovir prebrennissvir, which is your PI and NS5A inhibitor. So again, these agents are acting on 2 different target sites to inhibit HCV viral replication. This is data from the ASTRAL trials. So the first table, ASTRAL 1, is sofosbuvir valpadisvir, or brand name Epclusa, which is what we go by, so I'll just use that, for 12 weeks. And this is looking at genotypes 1A, 1B, and then 2, 4, 5, and 6. These are treatment naive and treatment experienced patients, and they are with and without cirrhosis. So if you look at that first table, really the SVR rates are excellent. So genotype 2, 100%, but really ranges from 97 to 100%. The ASTRAL 3 trial was looking at genotype 3 in non-cirrhotics and still at 97% efficacy. So greater than 90%, great. Our Mavorite or glisaprovir prebrennissvir trial for 8 weeks, this is only looking at patients without cirrhosis. So the Endurance and 1 and Surveyor 2 trials looked at genotypes 1, 2, 4, 5, and 6. And these were, I gotta look at my list because I can't remember. I think that it was both genotype, treatment naive and experienced. And then genotype 3, again, these are non-cirrhotic patients. And just the other thing to note with this is that the SVR rates were still extremely high, except if you look in the Endurance 3, if there was the A30K mutation, which eventually developed into the Y90 or Y93H mutation, then SVR rates dropped substantially, so down to about 75%, when in the other pools it was well over 90. So does that mean we should check for these mutations with our genotype 3 patients? So looking at data, the A30K mutation really only accounts for about 5 to 10% of patients with genotype 3. So really less than 2% of your patients will have this mutation. If you took 1,000 people, so remember about 20 to 30% have genotype 3 infection baseline. So if you took 20% of 1,000, 200 would have genotype 3, and then 10 to 20 of those would actually have this mutation that clinically decreased SVR substantially. So overall, out of those 200 genotype 3 patients, you'd still have efficacy of about 96 to 98%. If you didn't bother genotyping anybody at all, you'd still have about 98% efficacy overall. And if you did genotype all 1,000 to get your 99% rate, it's really very marginal numbers. So this is saying maybe we shouldn't genotype, right? So I'm going to give you guys a case study. This is a patient that I had, actually he was the first cirrhotic patient that I ever treated when I started doing Hep C. So I was all gung-ho and excited about treating him, but basically his liver cirrhosis was compensated. He did have sequelae of pancytopenia and esophageal varices, stable. He had underlying neurocognitive disorder secondary to a traumatic brain injury and chronic alcohol use. But when he came into my care, he was actually a resident of a long-term inpatient psychiatric facility due to schizoaffective disorder and had been there for quite some time. So at that time, we were genotyping everybody. He was genotype 3, baseline viremia 1.2 million, just mildly pancytopenic, CTP class A, MELD 9, and then no concern for ongoing risk factors or drug use or alcohol use because he's in an inpatient psychiatric facility. So I thought, hey, we'll do Epclusa for 12 weeks. He initiated this. So actually at this time, we really only had Harvoni and Epclusa, and then Sofosbuvir, I think, and Declatosphere were kind of our 3 agents that we tended to use. So Epclusa for genotype 3. He started that for 12 weeks in January, never came back until about August of 2017. And in that time period, I found he'd actually been transitioned to some other psychiatric facility, so was lost to care. When he came in from the new place, the records said, or records provided with him showed that his liver panel was stable and his HCV PCR was less than 15, and that was their minimum threshold value. And that was dated February 27th of 2017, so about a month after starting treatment. So he came in August, so he should have been finished for some time, but I didn't have any other labs, and I couldn't figure out when he actually finished because on his med list it still said Epclusa was active. So we got his SVR12 data, and it showed treatment failure. So PCR was still positive. And then when I spoke with the psychiatric facilities, kind of figured out at some point in his transition, he probably had about a 2-week treatment interruption. So what did I forget to do? Baseline. It was resistance testing. I had no idea this was something I should do, so I didn't do it. That's why I don't want you guys to forget to do it. But when we talk about our various polymorphisms, in certain populations, it is useful to test for pre-existing resistance-associated substitutions, or RASs, before you use certain regimens, because it does clinically have the potential to decrease efficacy of your treatment choice. So when we talk about NS5A polymorphism resistance testing, if you're using Zepatier, this is why. Genotype 1A, if that drug is being considered, genotype 3 in patients that have cirrhosis or that have had a prior treatment failure, we want to do this for Epclusa. or declatosphere sofosbuvir, which we don't use anymore. Why? Because it impacts your duration and or whether ribavirin should have been added. So he was somebody that I should have used Epclusa and ribavirin, and I didn't. So I checked this on him, because at the time, I still thought it was his treatment lapse that maybe had contributed to his lack of achieving SVR. And he did have that stinking 193H mutation. However, I never did baseline testing, so I don't know if he developed this on treatment or if this was already baseline. So takeaway points today. It's reasonable to genotype individuals with cirrhosis because it's important to know if they have genotype 3. Also, you want to consider genotyping the small number of people that we're going to see that are DAA treatment experienced. And then for those without cirrhosis, the benefit of genotyping really is pretty marginal, and the added simplicity of not genotyping and just using a pan-genotypic regimen makes the most sense. Plus, the genotype is about $1,100 bucks. So this is our guidance. And the only thing I want to point out kind of that we didn't really specifically covered was you really should still do your NS5A testing for genotypes 1A, whether or not they have cirrhosis, if they're treatment experienced and you're using Harvoni. What else might we want to consider? Well, our own epidemiology. So in West Virginia, hepatitis C either ranks number one or number 2, depending on what day you're looking at the data for acute cases in the US. So we may want to consider genotyping in our state from an epidemiological standpoint, and also to assess if this is a treatment failure versus a reinfection. The other big thing is that Medicaid, WV Medicaid requires your genotype on your prior authorization form and uses that as a guide for the treatment algorithm for the preferred formulary. So even though it's a cost, it's still required regardless of the circumstance at this point in time. And then just a quick note about Vosevi, which is our salvage, it's our pan-genotypic salvage regimen. This is really reserved for DAA treatment failures. And so you have your NS5B, your NS5A, and PI. So 3 different target sites. Data is limited, but it really appears that despite any resistance-associated substitutions, it really doesn't influence their SVR12, so still over 96% efficacious. Last slide, I promise. Assessment must include fibrosis staging. Treatment and assessment is now relatively simple. Genotyping really could be limited to just treatment-experienced patients and those with cirrhosis. And overall, pan-genotypic regimens really have a place for most, if not all, settings. Now we have to get through these cases. But do you guys have any questions? Sorry, it took longer than I thought.
You're fine. You did fine. You guys have any questions? Anything? If you think of something later, of course, you can always email us. All right. Joanna, are you good if I put up your case? I can't hear you, but I'm going to assume you're okay.
I'm good. Can you hear me now?
Yes, I can.
Great.
No, sorry. Oh, sorry. I think we're good whenever you're ready.
And they're going to help me. You can't hear me.
Now we can.
Can you?
Yeah.
Yeah, now we can.
Okay, good. Sorry. Hey, you want to switch me places?
Yeah.
All right, we're going to trade places. That'll help. All right, so we've got, I've got two of our nurses here with us. They're doing, we got a grant to do patient navigation for our hepatitis C patients. And so they have they'll probably be joining you guys a little bit more frequently than I am. They moved our management meeting, so I haven't been able to get on here as much as I would like to lately. I'm playing hooky on management meeting right now. So we'll talk about this patient real quick. This is I forget how old he is. Let me get him pulled back up. This is a 58-year-old male who came to see me for treatment of his hepatitis C a few months ago. He, I think, was diagnosed as part of our Suboxone program, which he's been in for the last several months. Jenna, do you remember if he had had any prior diagnosis?
No, he said that he did, but the record that we requested, they didn't show
They
that
didn't show
anybody
anything.
had ever tested him.
Gotcha. So he knew somehow that he had it, but we weren't able to find any of those records. So on his lab workup, he was pretty straightforward. He didn't really have any gross liver abnormalities. His AST and ALT were a little bit high. His vitamin D was low because everybody's is. His iron studies all looked fine. The only thing that was a little bit interesting about him is that his INR was slightly elevated at 1.4, and his Hep B serologies were abnormal. So his Hep B surface antibody was negative, Hep B core antibody was positive, and his Hep B surface antigen was positive. Okay, so that's what we knew at the time that we submitted this case. Well, we do have a little bit more information now. We got a Hep B viral load on him, which has confused me more because it was negative. So I'm thinking that, and you guys can tell me if I'm right or wrong, I'm thinking that his Hep B is non-detectable because it's suppressed by the Hep C, and it may become detectable once we start treating the Hep C. So his fibrosis score was an F1. We have an ultrasound pending on him, and we'll have that done on the 25th of this month. So my plan for him was to go ahead and treat the hepatitis C because that's his predominant virus. He's got a MELD score of 10, so he's not particularly sick with his liver at this point. I'm not too worried about throwing him into decompensation. And just really closely watch his liver enzymes, really closely watch his hepatitis B viral load. The one other person that I treated that had co-occurring Hep B, I think we did weekly labs for the first several weeks that they were on treatment. And my plan for him was to use Mavorite or Epclusa, probably Mavorite because we could get away with a shorter treatment duration. He's got Medicare, so I'm not sure what that's gonna look like, but what do you guys think?
Thank you for presenting, Joanna.
No problem.
Thanks, Joanna. That's a really good case. This is Kaylee.
Hey,
Yeah,
thanks.
I think it's cool because we really don't talk about positive Hep B surface antigen very often because we haven't had the opportunity. So there's a couple things I would ask you first. Do you know, as far as his risk factors, or if he'd ever been previously told he had a Hep B diagnosis or Hep B infection?
He did not. He didn't really specify. He said that he knew he had hepatitis, but he didn't say if he knew he had Hep B or Hep C, did he?
No, I think he thought he had Hep C because of the IV drug use with the people that he were around was also.
Gotcha. So, so his risk factors were just IV drug use, and probably unprofessional tattoos because everybody has those around here.
Everybody has them everywhere. What how recent was his most recent risk factor? Do you know? Like, I mean, even if he's been in Suboxone clinic for a while, is he ever injected or any illicit use still?
Okay. Yeah, he last injected September 2019. So he's pretty recent.
Okay. So, I mean, a couple things I would consider, particularly because he doesn't have cirrhosis. Right, we said, yeah, he said we maybe.
There's an F1 with a MELD of 10.
So I honestly may just wait a little while to see what happens with the Hep B. And the reason being is, I mean, his transaminases aren't high, but given that he hasn't had any previous diagnosis of either of these viral hepatitis, or at least confirmation objectively, you know, there's a possibility he could have an acute Hep B infection. Now, kind of the timeline, you'd see your Hep B surface antigen appear first and typically resolves within 6 months or so if this is going to be acute. Now his total core is already positive, so I certainly wouldn't think he'd been exposed within the first, you know, couple months or the last couple months. But there's also kind of this sweet spot where you don't really lose your Hep B surface antigen. So your surface antigen and your total core antibody are positive at the same time, even in the setting of an acute that's clearing. His viral load is already undetected. So, and remember, you can divide up your core antibodies between IgM and IgG, but when we're doing a total core, it doesn't usually separate those. IgM comes right after your surface antigen, but it can sometimes persist for a few years anyway. So if it was negative, I would be more inclined to say, yes, this is established chronic infection. But if it's positive, it could be acute or it could still be chronic. Regardless, I mean, his viremia is not present, so it may be suppressed by the Hep C. But I almost would trend his serology a little while longer just to get a clear picture. In all honesty, I mean, you can certainly treat him now, but you know, I don't necessarily feel that the urgency would be there unless you felt like it's something that this is the right time to do it. You have some time to kind of sort that out.
Okay. And I think we have.
Oh, go ahead.
I want to say his medication coverage is Medicaid, right? Yes. So we're going to have to wait until a 6-month repeat viral load on the Hep C anyway. So that's a.
So when were those labs drawn? The ones where you had the Hep B lab data? How were those checked?
13.
February 13th, so just a month ago.
Mm-hmm.
So probably around May, I would recheck your surface antigen and your core. And then I would also check your hepatitis B antigen and B antibody, the envelope proteins, and see if either of those are positive. And then recheck DNA too. And just to see where it's at, because if you've got a little time before treating them anyway, yeah, you could certainly go ahead and treat the Hep C and do exactly what you're saying, just monitor closely for flare, but it'd just be interesting to kind of get a trend of what his Hep B is doing over time.
Okay. And you said around May?
Yeah, usually I do
about 3 months. Okay.
But that's, yeah.
Would you?
And either of those treatment options, yeah, I think would be fine.
Okay, that sounds good. That's what we'll do then.
This is Rachel. Whenever you get, when you decide what, after this is all sorted out from a treatment standpoint, you've got atorvastatin listed here as one of his medications.
Mm-hmm.
So you'll just have to watch that. It's not recommended with Mavorite. And then so long as it's 40 milligrams or less, you could use it for, like, if you wanted to do the Epclusa or Harvoni for him.
Okay. Yeah, for some of our patients, what we've done, as long as they don't have, recent heart disease or, sometimes we're just having them hold it for a couple months, which
no biggie.
has worked out fine. Yeah.
Awesome. Do you have any other questions or anybody?
No, I think you guys nailed it.
Perfect. Thank you so much.
Thanks
we
so
were happy
much.
to see you.
Yeah.
Oh, I'm going to have to jump off and go to that meeting that I don't want to go to, but I'm going to let our nurses stay in here and hang out with you guys. So thank you so much. I appreciate it.
Thanks.
And Dr. Peters, are you cool if I pull up your cases? Is that okay?
Yes, although I didn't realize I had one, so I don't know if I'm
sorry, you have 3. do you want to do them or do you?
I'm happy to do them. Let me see.
Sorry about that. Here, let me show you.
Oh, it's okay. I don't care. Oh yeah, this guy. Yeah, I remember him. Yeah, we can talk. I can do at least one of them for sure.
Sure.
Yeah, so this is not nearly as exciting. This is just a simple 28-year-old gentleman who is quite obese. It came to see me just as a consult for treatment of his hepatitis C. He is immune to hepatitis B by serology, and his hepatitis A, he's had his first of his series of his hepatitis A vaccines. His labs are relatively unremarkable. He doesn't really have any elevation in his AST and ALT, no real transaminitis, and is a relatively straightforward player for him. You go ahead and scroll down if you would. He's a genotype 3 with a relatively low viral load. I think we were looking at Mavrite as an option for him to go ahead and get him treated. He doesn't really have any medication interactions that should pose much of an issue. His wife is also beginning he's one of our 3 married couples with hepatitis C that we're planning on treating concomitantly.
Awesome.
We'll probably go with Mavri, I think, because his I think they both have the same insurance. We have one couple that each have commercial insurance, and they're different. But I think he and his wife both have Medicaid, so we'll probably just sync up Mavri for them for 8 weeks for both.
Awesome. Sounds good. Do you guys get any, do you have any patients on Mavri? Because I feel like, I mean, I'm using it a lot just because we get away with the shorter duration and people like that. But do you guys get a lot of patients that have side effects of itching?
Have we heard about that? Have we heard itching for Mavri? Not that anybody's not that anybody's complained enough of to bring to my attention.
It must be a local problem. I swear that's like probably my most common side effect with Maverick was itching, and it's really not one of the top listed on the side effect profile. But so I was wondering yeah, I guess it's just me. Okay.
No, I haven't seen that. I'll keep an eye out for it though.
Yeah, I mean,
are they having a rash, or is it just the itch?
Rash. Yeah, no rash, this profuse full body itching to where they can't sleep. It's constant. It's just really impacting their treatment. And then Rachel has thankfully looked into it, and the data she seemed to get with from the reps was it's more likely with our CKD patients and with our cirrhotics, which kind of baseline, they may have that anyway. But this is like, hey, I just started 3 days ago and I'm having this really terrible itching. And so, we try to manage it with antihistamines, but I just wanted to get a poll if anybody else had that. Okay, well, if it happens, we'll talk about it. But thank you. Great.
And you don't see you don't see anything wrong with Mavri for 8 weeks, right?
No,
And
nope.
Okay.
Perfect.
Well, perfect. Greg, we can hold your other 2 cases for next time, or we can go ahead and shoot them through the on-demand thing, whatever you want.
Yeah, do you have a lot of other ones waiting, or do you have?
We have some, but
okay. Yeah,
like
that's sure.
Okay. Cool. All right. Anything you guys want to talk about? We're all here for another couple minutes. How's everybody doing?
Do you guys, I was just kind of more curious, just as a straw poll, do you counsel your patients on specific dietary modifications when it comes to their hepatitis C and progression of fibrosis, that sort of stuff? Like I make a big deal about avoiding things like high fructose corn syrup, processed foods, and that sort of stuff. I mean, it's probably good advice for everybody, but just because of NASH and concomitant things, I know glucose is metabolized in skeletal muscle and hepatocytes, and fructose is metabolized exclusively in hepatocytes. So I kind of I tell people to do that. I think it's probably just more good advice anyway, but I don't know if there's any reason specifically to do that.
Do you have anything? Okay.
Yeah. This is Jane. I don't tell them that they have to adhere to any restrictions unless they're under a fatty liver, and then I just tell them restricted calories, because I feel like whatever diet they're going to be willing to stick to, whether it's eating McDonald's twice instead of 3 times a day, I think that's better than what they were doing before. So I don't put any real restriction on anybody except to eat less.
I guess I just see is, as part of their workup, a lot of times, we'll get these right upper quadrant ultrasounds, and they basically all have fatty livers, right? So it's like, even if they don't necessarily have an elevation of AST and ALT, they'll have fatty. And so, my advice for a lot of those people is to do whatever they can to mitigate weight loss and to mitigate, going on a low or lower carbohydrate diet to try to decrease some of that. I don't know that that's any different advice really than I would give anybody else. It's just I end up looking for, I guess I end up finding fatty liver in these people more often because I'm imaging them, pretty consistently as part of their workup. So I wasn't really sure if that's something that you need to make a big deal about, or if it was just kind of to understand that their risk of progression of their fibrosis is just higher because it's there.
I think it's just the risk of the fibrosis is higher, but I would, if they just have, minimal or moderate fatty infiltration, instead of necessarily assigning fatty liver disease as another diagnosis to them, especially in the setting of hepatitis C, I would probably just try to have them address other comorbidities like diabetes and hypertension, et cetera. Because if you can get rid of the Hep C and they can control their blood sugars, et cetera, that fatty infiltration will probably wash out.
Okay. Any other questions?
Dead silence.
Everybody's taking in what you just said.
So I had a question.
Amy, go ahead.
Okay, so I was thinking about that previous case with the hepatitis B DNA that's undetectable.
Yeah.
Because I think where my training came from, we were still treating preemptively. Okay, but of course,
Treating the Hep B.
Hep B preemptively when you treat the Hep C. But of course, the DNA was negative. So I was looking it up because I was trying to figure out what to do with it, and it says like that's still an option, I guess.
You can.
But that's not the standard of care anymore.
Yeah, you can, but you don't have to. So I mean, if I have a patient that meets Hep B treatment criteria, independent of the Hep C, so still following the algorithm for treatment, then I would preemptively treat the Hep B. We honestly don't see a lot. I've had a few co-infected cases, but we really don't have an opportunity to go through it that often.
Okay.
But you can opt to, so like in this one, we could just treat, or even if there's low baseline viremia, I wouldn't preemptively treat. I would just bring them in. I don't know if I do it every week. I mean, I usually do every 2 weeks, and then even back off every month, as long as they're monitoring for flare symptoms.
Okay.
But I think it really has to be just a case by case.
Okay.
So
I've seen the Hep B reactivation, but I don't remember what their baseline value was. I don't remember that they were
if
active.
they were Cirrhos. So it was like a Cirrhos.
Yeah,
I mean, I'd have a lower threshold for that, but kind of generally overall, I would really just follow the Hep B treatment guidelines.
Okay.
And if they met treatment criteria preemptively, or even concurrently treat with the Hep C. But I don't tend to preemptively treat everybody.
Okay.
But
Have you seen a lot of people flare?
I've only
Kinda like
seen
a-
one reactivation, but they
yeah.
were on a DAA,
Yeah,
and they ended up fulminant and they died.
really. Well, see, and that's
Yeah.
a pretty big deal. I mean, that's
So, but I've only
pretty
seen
big
it
deal.
once. I've
Yeah,
only seen it once.
yeah.
So I don't know. I thought it was.
It's
With
scary.
the
It's scary.
the
Reactively
reactivation, if you get a reactivation, but their surface, I mean, I guess this isn't that case, but like, so if you have surface antibody positive, and you have core, like if they had just had natural infection for Hep B, but they're immune, you don't worry about that though, right? Because if it reactivates, they just clear it again.
Right. Huh?
I
You
said,
had
well,
somebody that was
Yeah,
antibody
so,
positive?
well, not with treatment of Hep C,
Oh,
but
okay.
with other immunosuppression
yeah.
in general.
In the setting
That
of
was
Hep C. So like,
that was my question.
like
Yes.
like a bio, yeah, that's a different case. But for Hep C treatment, if their antibodies positive, we don't see the reactivation. It's really surface antigen positivity, persistent Hep B viremia. Even the isolated core patients that we kind of say, hey, these are the ones to think about, because they still have that risk. The clinical significance of a flare is a small population, but we still kind of treat them as they're at a risk for reactivation too. But yeah, if their surface antibody is positive, we don't see reactivation with Hep C agents. Yeah, which is what we see, I feel like, a lot. Yeah.
I have a really quick question, which feels like cheating because I could look it up, but here we are. So I have a patient, he doesn't have Hep C, but he has past antibody evidence of past Hep A infection. Does that confer lifelong immunity, or should I vaccinate him?
So Hep A total antibodies positive, or Hep A IgG is positive, correct?
Hep A total, IgM was negative, I didn't get IgG.
Okay, get your IgG. Yeah, get
Okay.
your antibody to see if he, because it should be positive if he had a history of natural Hep A, and it would confer lifelong immunity.
Okay, good.
But there's always the cases that I've run into where they're like super like sure that they had Hep C vaccine or they had Hep B, you know, and so I always clarify my serology because they may have thought for sure they had Hep A and then total antibody negative, they didn't have Hep A, you know.
Thank you.
But yeah, if that total antibody or the IgG is negative, then go ahead and vaccinate.
Okay, beautiful. Thank you.
Yes, if it's positive and they've had a history, it would confer lifelong immunity. You don't need to vaccinate. Good questions. Anybody else? Because then we'll chat out.
All right. Thank you all so much.
Thank you, guys.
We appreciate the cases. So our next session is on the 26th, and Rachel is giving our didactic. Do you want to tell them what it's about?
I'm just going to go over the different regimens.
Sweet. Yep. I think it'll be really excellent for everybody, of course, as a refresher, but especially for new folks. If you guys definitely want to come and sit in on it, I'm going to invite some more people who've signed up recently to try to get them here if they can. So thank you. Everybody have a wonderful day.
Thank you, guys.
Somebody email me about